So now we move on to the second talk. This is very special because Dr. Sandeep, our good friends, he will be online. Yeah, he supposed to join us in this second SIF because some issue at home. So he will join us from UK. So Sandeep, thank you very much for joining us. And then now the stage is yours.
Hello, can you hear me?
Okay, you got the right name now. They heard you. Hi, Sandeep. Can you hear us?
I can hear you. Can you hear me?
Yes, I can hear you. I'm Liu here. Good to see
Perfect.
you. Okay, go ahead.
Thank you
We are
so much.
already
And
here.
good afternoon, everyone. I'm really sorry that I am not able to join this meeting in person because of some family issues. So please consider my sincere apologies, and I'll be there next year. And I'm going to miss a lot of fun, which you think you're having. I'm seeing some photos. It's amazing. So thank you once again for the invite and accommodating my online talk. So I'll be talking on DCB in STEMI. Does it offer any advantages over drug-eluting stent? So the main goal of STEMI PCI is to establish a TB3 flow and to keep the procedure simple and short. However, some factors that hinders this goal are high thrombus burden, slow flow, especially post-stent deployment or optimization, complex anatomy, and the other problem is we tend to undersize the vessel during STEMI. So let me show you a case. So this is a inferior STEMI with a proximal occlusion of RCA. After we balloon and establish TB3 flow, the operator put two long drug-eluting stents. And as expected, you see there is a slow flow, and which is often seen in this kind of a situation, and patient became extremely unstable, and we had to give lots of inotropes, and finally with adenosine we managed to establish TB3 flow. Now, is there a role for DCB in STEMI? So what are the advantages DCB offers? For me, one, it simplifies the angioplasty. One balloon, one DCB, one wire, and we generally finish. We don't need IVUS unless it's a lesion is complex with calcium. So for me, it simplifies angioplasty. You don't have to protect the side branches and things with the DCB. Of course, it maintains the original anatomy because there is no metal, and it gives the liberty of stopping the DAPT, especially if there are any future issues with bleeding. Because often in STEMI, we don't know the patient profile very well, and we later find out that they have bleeding problem or cancer, in which case, we'll be stuck with the stent and we can't stop the DAPT. Whereas with the DCB, we have that option to stop the DAPT if needed. And of course, no risk for any stent-related events like thrombosis or restenosis. Let me show you. This is a case of a 39-year-old. Actually, he's a colleague of mine, endocrinologist, came with the inferior STEMI. And you could see there's a lot of thrombus burden blocked mid-RCA. So after establishing flow with some gentle balloon dilatation, we use two long sirolimus coated balloon. I tend to use more sirolimus in the DCB, especially STEMI, because of less particulate embolization and hence slow flow. So this was the final result, TB3 flow. Patient was asymptomatic, ECG resolved. And we sent him home, and he came back a few months later for a check angiogram. And look at this. This looks great. We didn't place any stent. More importantly, it's even difficult to see where the lesion is. And also for me, the most important is look at the way the artery moves. It has a natural motion of longitudinal contraction and radial contraction, which would have been caged if you had placed the stent. This is another case, anterior STEMI. One balloon in the LAD, just protected the diagonal. Post POBA, you got a good result. Diffuse disease. So we put one long DCB, and I often do this after the balloon is inflated. I inject some contrast to see if the contrast is going past the balloon. If it is going past the balloon, then I go up with higher pressure, and I left it for a good 90 seconds, and we had a good TIMI3 flow, and we did not put any stent here. However, there are some pitfalls of DCB in STEMI. One of the things I get asked is, can the drug be absorbed in presence of thrombus? What about particle embolization, especially for crystalline formulations like paclitaxel? And of course, the most important is lack of evidence. There are no proper RCTs comparing stents to DCB. We have mainly observational data. There is a trial called Copernicus ongoing in Spain, comparing paclitaxel DCB versus stents in STEMI. Obviously, it will take a couple of years to see the results. And in UK also, we are doing a study called STEMI trial. We should be comparing a paclitaxel with stent, and obviously recruiting ongoing. I would like to show this small randomized trial presented in 2019, where they enrolled 120 patients to DCB or stents. And this was mainly an angiographic endpoint study. So they did the angiograph follow-up at 9 months to show that late lumen loss was similar in DES and DCB. And they presented clinical outcome at 2 years, and there was no difference. But this is a very small study with 120 patients, so it's very difficult to draw any definite conclusions. In my practice, I still use stent as a first choice because of the evidence. However, I use DCB in following scenarios like small vessels, diffuse disease, younger patients, elderly patients with DAPT issues, and unusual anatomies like ectasia, isolated side branch occlusions. Let me show you this case. This is very nice. So this is a 56-year-old man with chest pain, and the ambulance ECG shows some lateral ST elevation, mainly the high lateral leads. So it's a lateral STEMI. You could see clearly here V5, V6 elevated, and 1 and AVL, and some reciprocal changes in the inferior leads. The right coronary was non-dominant, and we did the left system. So left main is okay, dominant circumflex is okay, and even LAD looks okay. There's mild disease. Then we took more pictures. Initially, we were kind of struggling to find the culprit. But then if you look very carefully, something missing in the diagonal here. And this area is not supplied. So we just wired it. And you see it's decent branch. So we did a gentle balloon dilatation and established TIMI3 flow. Patient became asymptomatic. So how would you treat this? This is the culprit. D1 is not blocked, and LAD is mild disease. So if you want to treat this in a stent fashion, you will have to convert this into a 2-stent strategy, because you cannot land a stent right at the ostium because of the angulation. So we decided to use DCB, but for DCB, you have to do better lesion preparation because there's a clear recoil in the ostium, and you cannot accept this as a good lesion preparation. I'm sure Liu Bang will agree with this. So we used a scoring balloon, and post-scoring balloon, you see that there is definitely less recoil now. It looks much better. And then we used a long DCB. The advantage of using DCB here is that we brought the balloon back into the main branch so that we covered the ostium nicely, and you cannot do this with stents, obviously. And I told you earlier, I inject dye to make sure it's blocking the diagonal so that it completely opposed and the drug has got a chance to go into the artery. And we had a TIMI3 flow like this. So for me, this procedure was simplified with the DCB in an isolated side branch occlusion. Second case, anterior STEMI and some moderate disease in the RCA. So again, blocked LAD, wired balloon, and you could see it's calcium there. So we did further ballooning, and we used a cutting balloon, and post-cutting balloon, there was some recoil, but here, because patient had some bleeding issues, so we wanted to avoid stents here. So we used a long DCB, and we had TIMI3 flow. Patient became asymptomatic, ECG resolved. So we accepted this. And patient came back for an angiogram 4 months later because he had some disease in the RCA and he was completely asymptomatic. And this is the angiogram. And this is one of the mistakes we do in DCB angioplasty. This was done by my colleague who, instead of accepting the medical management because patient is asymptomatic and it looks good, they decided to do IVUS. And I was slightly baffled why the IVUS was done. Now the IVUS basically show diffuse LAD disease, and if you look at the plaque burden, it is 70%. And my colleague wanted to place a stent, and the stent would be 80 millimeter long. And I was surprised. And then I said to them, look, why don't we just do an intravascular assessment of the flow physiology? So we did the physiology and it was 0.93. So it's negative. And more importantly, look at the step up, diffuse step up in the LAD. So which means if you want to stent, you'll be placing a long layer of stent. So we avoided stenting and medical management. Can you all hear me still?
We can hear you clearly.
Oh, sorry, thanks. So DS should be the first choice in STEMI. However, DCB offers several advantages over stents, but we need strong data to support this hypothesis. But in the meanwhile, we can use DCB in selected patient and lesion subsets, as I've shown some of the cases. Thank you so much.
Thank you very much, Sandeep. You can stay with us, is that right?
Yeah, of course, of course.
Okay, if you can stay with us, then we'll go to the next talk.